And the other thing we also recommend in bladder is vitamin C, 2 grams a day. That helps acidify the urine to prevent infections, which is very important as well. So things like cranberry juice that people recommend, that helps acidify the urine but has a lot of calories, so we recommend the vitamin C instead. Just straight vitamin C? No, I recommend vitamin C, either 1,000 milligrams twice a day or 2 grams a day to help acidify that urine to prevent infections. And I would say, because I see more of the adults, when I have to sign for things, I typically will see 120 caths a month. So that would be 4 a day that come across me. And I can't say I see much less than about 120 a month. So that would give you 4 a day over 30 days. So next up is going to be our physical and occupational therapy team to discuss functional activities and skills. And that includes Terry Zakwarchemny, who's the Assistant Director of the Occupational Therapy Department at Kennedy Krieger Institute. She's been a member of our Spina Bifida Keelty Center team for the past 7 years, and she treats and evaluates children with learning disabilities, motor coordination and sensory processing disorders, autism disorders, CP, and Spina Bifida. She also runs an exercise group for our obese patients with Spina Bifida as well. Leslie Frank is an occupational therapist who works in the seating clinic and helps assist with our seating needs. And Elena Bradley is a senior physical therapist from the inpatient department at Kennedy Krieger Institute, who will be transitioning later in July, it sounds like, to the outpatient department. But she evaluates and treats children with acquired brain injury, cerebral palsy, chronic pain syndromes, complex medical conditions, developmental delay, and complex neurological conditions, including Spina Bifida. So welcome. Thanks.
All right, I'm going to switch out here. What do I need to do here?
This slide. Custom slideshow.
This one? Try it. Okay. Sorry, my contact lens is, of course, just now starting to bother my eye. Okay. All right, so we're going to be talking about more of the orthopedic areas of spina bifida and how that relates to mobility and function in everyday life. So patients with spina bifida have long-term orthopedic, neuromotor, sensory, mobility, daily living skill, and learning needs that can be addressed with physical and occupational therapy. One thing that we all know and have found is that coordinated care and caregiver understanding and agreement with the plan of care is vitally important and essential for the children's development. With most kids with spina bifida, we can expect that they're going to have delays in their development, especially when it comes to developmental motor milestones. For children who has spina bifida at the level of L5 and S1, on average at 1 year of age, these kids have about a 4-month motor delay. At 18 months, that motor delay increases where they're about 8 months behind. And at 26 months of age, there's often about a 10-month motor delay. With regards to secondary conditions, a lot of the things that we see as PT and OTs involve things like joint contractures, including foot deformities where patients can have club feet, calcaneal feet, and varus and valgus deformities. As Dr. Schultz mentioned earlier, hip dislocation and scoliosis are big problems for our patients with spina bifida. Osteoporosis, skin breakdown, obesity, and learning problems, including attention, poor organization and sequencing, visual motor deficits, and fine motor and coordination deficits as well. So these are a lot of the things that we're going to be working really hard to prevent with our children, in addition to working on maximizing their function in their everyday lives. So when we're looking at PT and OT and what we work on, there's a lot of overlap between our disciplines. Some things are a little bit more distinct. For instance, PT will look really specifically at things like bend mobility, transfers and transitions, locomotion, developmental gross motor skills. cardiovascular endurance, and then looking real closely kind of at the myofascial systems and joint mobility. And then I'm going to let Terry talk a little bit more about OT and how we overlap.
So OTs, we're going to look at their self-care skills is one of the priorities, and then that would be kind of like we see that as the outcome, but we're going to look at their developmental fine motor skills. We're going to look at their visual motor skills. Visual motor skills, I call those visually based motor tasks. So writing skills being a big one, but also cutting with scissors and anything that's requiring the hand-eye coordination. We look at visual perceptual functioning, so how are they in terms of visual perceptual skills, being able to discriminate spatially within their environment. We also look at oral motor and swallowing skills. And then as Elena said, there's a lot of overlap. So both OT and PT are looking at pain. We're looking at what the child's muscle tone is, what the child's strength is. We're looking at range of motion. Now, there tends to be, like we tend to focus more on the upper body strength, what's their shoulder strength, what's their hand strength. PT is looking more at the lower extremities. But we're both looking at balance and equilibrium, which are very important for transfers, and gait and all of that. We look at their skin and sensation. We do orthotics with PT, of course, looking at and doing most of the lower extremity orthotics, and there are some instances where they need some upper extremity splinting or would benefit from that, so we look at that. We both look at adaptive equipment, mobility, and seating. In a little while, Leslie's going to talk more about the seating clinic. Here at KKI, we have a seating clinic that involves both the occupational therapist, oftentimes the physical therapist, both together, and the vendor, the equipment vendor, and the family. So we all look at posture, positioning, safe transportation. And that includes car seats, and then access to home, school, and community settings. So for occupational therapy, the areas that we evaluate, we're going to look at basic ADL, which is your grooming, your hygiene, your bathing skills, dressing skills, both upper and lower body, and then toileting. We also are going to look at how do they transfer from their chair to bed or chair to mat or chair to tub transfer, toilet transfer, those things. And then we also look at what we call the instrumental ADL or IADL, and these are things that are higher functioning. So these are things like basic kitchen tasks, food preparation, things that they need for community living skills, leisure and play activity. So as you can see, it's depending on the age of the individual, we're going to look at different areas of IADL. And then with equipment needs, we wanted to mention this slide because often items that are covered by insurance are your wheelchairs, your standards, your walkers, your crutches, AFOs, and splinting are often covered by insurance. But then there's a lot of items that really individuals with spina bifida and our wheelchair population would really benefit from in terms of their life satisfaction, but they're often not typically covered by insurance. And so this is where we might try to contact the case managers and see if we can come up with, is there an alternative funding source that can help these families for this equipment. And those include things like our tub benches, shower chairs, adaptive toilets. And it's really important with the toilets, for that trunk support and to have some type of support like a armrest or something. Grab bars, self-help equipment like feeding equipment, bathing, dressing, grooming, toileting equipment, positioning chairs. These are not your wheelchairs. These are like adaptive seating chairs that sometimes the kids can use in the classroom or the younger kids can use to do fine motor work. So, and then there's car seats and specialty transportation equipment. And I did bring just a couple of things, like, that you would consider that kind of equipment, like everybody knows what these are, the reacher. And then we've got, and it could be something basic like a grip, which we'll talk a little bit fine motor. This would go around some type of tool and it might help somebody who has a weak grasp to be able to grip objects. And then we've got the mirror, which we often recommend and use for skin checks. It's helpful for people depending on positioning.
Okay. So as I talked about before, in general, as a PT, our role is to really look at the child's gross motor skill development and how they're able to move and be functional in all different kinds of environments, from their home to their daycare setting, to school, to outside in the community. Things like being able to get on and off the school bus to get to and from school. Any kind of environment that you can think on is an area that the PTs might want to work on with the child. We're also going to be looking at the child's balance and coordination, their posture. For our kids with spina bifida, their endurance and their physical fitness is going to be very important throughout the lifespan, because as we've talked about, these children are really prone to things like obesity. And so in being involved in some type of wellness program or physical fitness activities is going to be really important for helping to maintain their weight. We're going to be looking at their movement patterns and how they're doing things like sitting, standing, rolling, and really encouraging and helping to promote normal movement patterns as much as we can. We're also going to be looking at pain, especially over the lifespan as these patients get older and are using certain muscles and certain joints in repetitive manners. They're going to be a lot more prone to pain. Of course, strengthening is going to be an issue for these patients in both areas of their body, above the level of their lesion and below. And then maintaining and improving range of motion, muscle length, and tissue flexibility.
So some of these same things, of course, OTs are going to work on. We're going to work on improving their independence first improving their participation in, and then improving their independence with their self-help skills, which includes play and leisure activity. Building the sensory and motor skills. We either do that through compensation, or we work, by setting up the environment or looking at the equipment and making some recommendations there, or we do that through skilled training with a lot of activities for postural control and hand-eye coordination and fine motor skills. We want to work on their oral motor skills and swallowing problems, and we'll often do that in conjunction with speech, in conjunction with nursing. And then fine motor and visual motor delays, positioning needs for everyday kind of activities, and then, as Dr. Schultz had mentioned, to health and wellness. So we want them to be able to participate regularly in exercise. That includes wheelchair exercise. So OTs might suggest practice activities for independence with self-care skills. So we might, even working on things like opening various containers, working on fasteners. We guide their participation in childhood occupations such as play to build coordination, strength, and dexterity. So depending on what their needs are, you might see an OT working with them on bead stringing or on lacing, or depending on, if you're working on large muscle groups to improve skills, or if you're working on small muscle groups. We look at the task and we analyze it for the skills that are needed for that task, and then we work with the children on that. For children with spina bifida, and specifically, because we're working towards self-catheterization, which is a lot of tactile, so you don't really have your vision to guide your movement. So we'll work on a lot of these activities and have them close their eyes. So they're really working on developing some tactile discrimination skills. And we may do some simulated self-catheterization activities where we're working with putty and more resistive materials and positioning and things like that to help work toward independence there.
So through both PT and OT, we find that our children can be positioned more comfortably with proper alignment. We can work together to improve their sitting and their standing balance, working on improving their mobility and gait, helping them be able to demonstrate safe and independent movement, whether it be by walking or in a wheelchair. We're able to help them access their home, their school, and their community. We're able to help them have better breath support, perform self-care tasks more independently, play games with their peers and their families, eat and drink safely, participate in various school activities, and learn ways of taking care of themselves and feeling good about themselves. So for the next part, we thought it would be helpful to kind of look at mobility and motor development kind of through different ages of the lifespan. So what we're going to do is break down our discussion into infants and toddlers, so from 0 to 2-ish, then preschool age kids, then our school age kids, and then we'll talk a little bit more about kind of that adolescence and transition to adulthood. And the assessment and the interventions of these kids at different ages will vary depending on their age and the level of their spina bifida. But the long-term goals for all of these patients are going to be similar. So for all of these patients, we want to look at maximizing all areas of their function and make them as age-appropriate as possible. For all of these patients, we want to prevent secondary conditions and impairments such as obesity, deformity, osteoporosis, and maintaining their skin integrity. And then again, for everybody, we want to promote exercise, fitness, recreation, and their ability to participate in school and community activities. So from a PT perspective, when we're looking at an infant or a toddler, again, we want to encourage the normal development of skills. And we know that there's going to be a delay for these children, but we want to promote as much normal movement as we can. So in this infant and toddler stage, there's going to be a huge emphasis on the parent and caregiver education in terms of understanding the level of the lesion that their child has and what muscle groups are going to be affected by that, and how their handling and positioning of their child can have such a big impact on the development. PT will often be carried out through early intervention services, and some children in this early stage may also benefit from coming to PT as an outpatient. We want to, as we talked about, really promote that normal motor development, and so that's going to mean helping the family know how to position their child both on their back, to work on allowing the children to have free movement of their legs in a straight extended position, but we also want them to be able to learn to put the baby on their belly for a good chunk of time during the day to encourage head and upper trunk control. And then when the child is able to have better control over their trunk, their upper trunk and their head, they'll start to work on things like sitting. And we may encourage use of lots of household typical items like pillows, boppy pillows, to prop around the child so that they can sit a little bit more safely. And when they have better control over their trunk, they can start to work on standing activities. So these are all things that a typically developing child would work on as well, but the family's going to need a lot more guidance in terms of knowing when to start these things with their children, and really to hone in on particular patterns of movement and things to look for in their child so that they can help their child have the best outcome. The therapist's role in this early stage is often to really to help guide the parents in knowing what they're going to do, because the parent is going to be spending 24 hours a day with their child, and the therapist may only come in once a week for an hour. And so the parent is really the therapist at this point, and we want to be able to empower the parents to really guide their children and be very successful with them at home. Actually, let me go back for a second. In terms of prevention of deformity, in addition to working on the mobility, one of the things that we're going to have the parents do every day with their child is work on range of motion. We talked before about how these children are really prone to getting contractures at their hips and their knees, so daily stretching activities are going to be important for these children, whether it be just in positioning or actually specific stretching activities. We're going to look at their need for orthotics or splinting. And again, the role of splinting or orthotics is to maintain position of the joint and flexibility of the muscles. But because these children often have impaired sensory systems, very close monitoring of the skin is going to be important to prevent skin breakdown. And they may need the therapist to help guide in terms of, how much redness is okay, because oftentimes when you first take off an orthotic, you will see a little bit of redness. But we'll help to guide the parents to know that if the redness doesn't fade away quickly, then they should be concerned and talk to the therapist about making modifications for any splints. We're also going to look at any needs for adaptive equipment in this early stage. If you look down at the end, there's a mobile stander that we often like to recommend for our children in the toddler age, so that they can be upright in a position that is in a supported standing position, and they can learn to be mobile by using their hands to propel the wheels. They can push the stander around the house or their daycare setting, because being in that upright standing position is really important for them for social interaction with their peers and for various other bodily functions as well. And I'll talk more about the stander in a later slide. A lot of adaptive chairs and seating equipment is going to be important for these younger kids as well, and we'll talk more about those as we go along.
So with the infant and toddler in occupational therapy, we want to promote fine motor development and sensory motor integration through play. We're really looking a lot of times when we go in to see these little guys, how are they interacting? You know, how is their regulation and how body regulation, and how's their eye contact? Are they tracking? Are they participating in that social engagement? We're going to identify upper extremity neurological deficits, so we're going to look for muscle tone. We're going to look at their head and trunk control and their and what their underlying muscle tone is like, and is there any asymmetry in their upper extremity patterns. We're going to look at oral motor function. So with the younger infant, we want to look at that suck, breathe, swallow synchrony, and are they coordinating that suck and swallow well? Are they having any issues with that timing and that sequencing? And then as they start to take foods, how are they doing with the oral motor skills, and are they able to tolerate the change in textures from going from a bottle to more of a solid or puree food, and eventually with the chewing and just with the toddler, a lot of times sometimes their oral motor skills are not so terrible, but their pacing is a little bit fast. So we want to kind of work on that kind of pacing aspect of feeding by providing some cues for that. And we want to promote age-appropriate self-help skills. One of the questions I always ask the parents, too, with infancy is how are they tolerating that? How do they tolerate the diaper changes? How are they tolerating the baths? And, how's that regulatory system? And as Elena had said, educating parents and caregivers on handling techniques and home exercises is a really strong component of that. And if they are kind of irritable or fussy and having difficulty with their changes, looking at positioning and ways of kind of helping to relax the atmosphere for both the parent and for the child. And we want to make sure that the child's getting the appropriate early intervention services. They may, depending on the level of the spinal cord, the lesion, and depending on what their functional skills are in terms of if they're not having any oral motor problems, or they're not having not significant upper extremity issues, they may not be receiving OT at this point in their life. So, but we're still, like here at Kennedy, we're still going to monitor them for every 6 months or so, every other visit, just especially as they start to get into the toddler ages, and we want to be able to look then a little bit more at their hand-eye coordination and some of those visual motor skills and self-help skills. So these are some of the upper extremity splints that I tend to see we more often might use for patients with spina bifida. This is called it's actually called a Joe Cool splint, so it's pretty basic, but a lot of times these children have the low muscle tone, and so they don't have very good strength, stability in their thumb. They have some of that laxity. So these just help to position the thumb so that it gives a little bit more stability here, and then we can work on developing or the pinch so they don't get into this kind of a lateral or side pinch pattern. And then as they get older, we might have to incorporate a little bit of the wrist in it if they're depending on how their wrist position is. And then sometimes with the adults, mostly more with the adults, we monitor them because they might be prone to more peripheral nerve injuries like carpal tunnel, because they're, obviously they're using their upper body so much and with repetitive activities. So we look for that and may have to provide some type of a orthotic or cock-up splint or something to help manage the pain with that.
And these are just two pictures of some common lower extremity splints that you might see in some of these younger kids. The yellow one is an example of an an ankle-foot orthotic. And this is a solid design where the ankle is fixed and doesn't move. But there are many children who might benefit from an articulated ankle joint, or even a smaller AFO that doesn't go all the way up to the knee and just encompasses the ankle. It really depends on the child's strength and the level of their lesion. And then the bottom picture is just a picture of a knee immobilizer, which is really helpful for some of our younger kids who are starting to do some standing activities, where we can immobilize the knee and really concentrate on the hip strength and the extensors there, and also the trunk, to really incorporate some standing at a table, at a play area, and allowing them to get some weight bearing through their legs even before they're ready to start trying some ambulation activities. And these are just some pictures of the mobile standards that I touched on earlier. And so basically what it is that the child's placed in the stander with their belly against the front pad. And the wheels are so big that they're able to use their upper extremities to propel themselves around their environment. So this is a great means of alternate positioning and mobility. It provides a nice stretch through the front of the hip to get the hip flexor stretched out. It allows the child to be upright and social at the same height level as their peers. And it promotes their mobility and their exploration in their environment. As I said, it helps to prevent contractures, and it's also going to really aid in pulmonary hygiene, digestive function, and if the child's able to use their arms to propel, really work on some cardiovascular function as well. Go ahead, Lauren. Yeah, it certainly depends on the child, but and also the size of the stander itself. But as soon as the child is developing the ability to sit up on their own and looks like they're starting to progress to starting to pull up to stand, I would say go ahead and put them in a mobile stander and get them moving around as early as possible. And we'll talk a little bit too more about that from a seating perspective and how soon you would recommend a chair for a child. But I think we agree that as soon as the child is ready to be interacting with their environment, the more promotion we can do for that kind of exploration piece is great for them. Okay, so we're going to move on a little bit to kind of the preschool age. And at this point, we're going to continue to really look on increasing their gross motor skills. And some of these children may be ready to start thinking about ambulation. And we're going to be assessing their need for bracing and what types of assistive devices might be helpful for them. Direct physical therapy might be still through early intervention services. If they're in a preschool setting, they may be eligible for school-based services and also may be coming to an outpatient center. We want to continue to prevent their secondary or impairments or deformities and continue to look at splinting and orthotic needs. And look at the need for adaptive seating and equipment. I'm going to go back for just a second. With regards to ambulation, we talked a little bit about the standards, but I think one thing that's also been explored more is the use of body weight supported ambulation, either on a treadmill or over ground, and certainly encouraging kind of that normal stepping pattern early on may be very helpful for some kids in promoting ambulation as they get stronger and older. And there have not been very many studies done with body weight supported ambulation in patients specifically with spina bifida, but we know there's been a lot in the spinal cord research. And there's also been some in the Down syndrome research as well. And some therapists that I've worked with have really used kind of the Down syndrome literature as a basis for treating kids with spina bifida in terms of the treadmill training, and will advocate for really early on use of body weight supported treadmill training once the child is starting to show signs of being able to initiate steps. So it's certainly a route that's beneficial for these kiddos.
And then for preschool age, this is a big age for us actually to start discussing some self-help skills and working on some independence there. A lot of times the families we work with, at this age, they're very much focused on the walking. And so that's very important to the family. And a lot of times when we start talking about self-help skills and independence, it's kind of like, well, yeah, but it's a time constraint, or it's easy for me, to to do the activity. It just doesn't come to the forefront of their mind. So we talk about their independence with self-help, and also how it can help to promote their fine motor skills and dexterity, which will be important when we start talking about CIC. But we're going to promote fine motor development, hand-eye coordination. We start looking at really early kind of pre-writing, early writing skills, and how their ability to copy paper, pencil, crayon, paper kind of activities. We're going to look at for upper extremity weakness, again, or any kind of follow through on any kind of oral motor dysfunction that may be present. Again, the self-help is really important, educating the parents and caregivers regarding the deficits and the service recommendations, and then following up and making sure that they're getting early intervention services. And at this point, too, we might start providing them with some school-based through Child Find services and possibly outpatient services to look a little bit more with some upper body strengthening and stability kind of activities.
So these are just some additional pictures of different types of bracing that you might see for these patients. And the yellow one is an example of a TLSO, or a thoracic lumbar sacral orthosis. And these are often used in children that have significant scoliosis. I think it's important to keep in mind that a brace like this is not necessarily going to stop a spinal curvature from happening, but for some of our patients it may help to slow the progression down, and it may delay the need for surgery in the future, but again, it's not going to completely stop the scoliosis from occurring. And one thing that we always weigh as therapists with our children when we're thinking about bracing is kind of the catch-22 in terms of immobilizing an area which is going to weaken it because you're not able to use it functionally, but also promoting the alignment and the support that you need. So for a lot of our children with all different kinds of bracing, we may recommend that they be in it for some portion of the day, but also giving them time out of their bracing so that they can work on specific strengthening activities, whether it be with their family or in therapy. The bottom brace right here is an example of an HKFO. And then the other one is a KAFO, so hip, knee, ankle, foot orthotic versus knee, ankle, foot orthotic. And prescribing these will depend on the child's strength, the level of their lesion, and what they're able to do functionally. In terms of strengthening, again, we talked a little bit about kind of the body weight supported treadmill training. For some of our children, one of the most successful areas in terms of strengthening and activity for them is getting them in the pool, because the pool allows them to be more mobile. They don't have the effects of gravity that are working against them, and it's just such a fun environment for the patients that it can be a really great therapeutic tool. These are all examples of some of the assistive devices that patients with spina bifida may use. The green one is a gait trainer. It's called a Rifton Pacer. And this allows the child to have some of their body weight supported when they're standing. And there are a lot of components to gait trainers that you can switch in and out depending on how much support the child needs. You may be able to give them some forearm supports, more or less chest support, depending on how strong they are. But as the child gets stronger, they may be able to progress out of a gait trainer to a walker, such as the blue one up top, which is an example of a reverse walker. So the child would have that behind them and pulling it with them when they walk. And then again, for some children who are stronger, who may have lesions a little bit lower down, they're able to walk with forearm crutches. And I'm going to talk next a little bit about different levels of injury and how that might affect their mobility. So this chart just shows a really kind of brief description of different levels of lesions, what muscle groups are innervated at those levels, and then kind of a general guideline of what type of mobility these children may have. And I think it's important to keep in mind that not every child will fall neatly into these categories, and that you may find some children who are doing more or less walking, even with the same lesion. So thoracic level lesions, these children may ambulate for some form of exercise, but over time and in the great scheme of things, it may not be a very functional means of mobility, because it will be a lot of extra effort from a cardiovascular standpoint and energy expenditure standpoint for them to be able to walk all day long. So often for these patients, a wheelchair is necessary for functional mobility. For patients that have L1 level spina bifida, their hip flexors are innervated. So they may do pretty well with long leg braces, but still may need a wheelchair for community distances. When you get to the L2 and L3 level, the quadriceps and the hip adductors are innervated. So the patient may be able to ambulate with forearm crutches, but still may need a wheelchair for longer distances. At L4, they have their hamstrings and their ankle dorsiflexors innervated. So they can be a functional ambulator with AFO, so the smaller leg braces and forearm crutches. But when they're first starting to walk, they may still need to use some of the longer leg braces. And they, again, may need their wheelchair for longer distances. At L5 and S1, the hip extensors, the hip abductors, and the ankle plantar flexors are innervated. AFOs might still be needed, and they may need crutches or a cane to decrease their energy expenditure, or also to increase their safety because of falls. But typically, these patients don't require the use of a wheelchair. And then at S2 and S4, you're going to get the smaller muscles of the foot innervated here. So you may need just typical shoe inserts as orthotics, and may be able to walk without an assistive device. When the children become school age, our focus is going to shift in some regards because they're going to be in a school environment, and we want to make sure that they are as independent as possible in the school setting. So they may be receiving school-based PT services and may continue to come to outpatient clinics as well. We really want to encourage their participation in their family and their school and their community activities. And as we talked about before, promoting a physical fitness program is going to be really important for preventing obesity down the road. Things like low-impact aerobics, swimming, cycling, rowing, adaptive dance, or yoga exercises are wonderful. Here in Baltimore, we have the Bennett Physically Challenged Sports and Rec program, and Kennedy Krieger has also opened up a new wellness center here, which is an option for these patients as well. We're going to continue to look at their secondary impairments to prevent deformity, continue to assess their orthotic needs and what types of assistive devices they might need for mobility and seating.
So again, for the school-age child, we're going to promote, OT promotes development of self-care skills and also assessing for adaptive equipment, assess and treat fine motor and visual motor deficits for school performance. We really strongly look at their visual motor skills and how are they approaching like writing activities. And I won't go into too much depth with that because I know we have neuropsychology who's going to be here in a little while and talk about problems with sequencing that kids may have. And when you think about motor sequencing, it's, when you think about your larger motor actions and sequencing to coordinate jumping jacks or something like that, that's one aspect of sequencing. But also a lot of the activities, the visual motor activities, when you're doing writing, it's a lot of sequencing involved in terms of down, up, stop, start, change directions. And we want to look at how are these children able to plan that and process those. Oftentimes, kids will see, typically developing kids will see the letters and watch how the teacher's forming it or someone else is forming it, and they see it and they can kind of process and plan it, and they say, okay, well, I'm going to make it like this, and it's pretty efficient. Sometimes children will look at letters and shapes and patterns and they see it and they know what it's supposed to look like, but they can't quite figure out how to sequence that plan. And so they end up getting there, but kind of in a roundabout way. So you want to try to look and see if these, what I call them bad habits or patterns, so that you can start to intervene early and try to help the child develop some of those better sequencing and planning patterns. We look for upper extremity weakness or oral motor dysfunction. In our clinic, usually about the age of maybe 6 or 7, maybe 7, but we start taking grip and pinch strength. It's not so much in comparison to what the normal population. There are some standardizations on normal population, but there's also been studies that show that individuals with myelomeningocele, they tend to have a weaker grip strength in general. So I'm not comparing, but more for the child, the individual themselves, to look at it over time. And then if we do see that their grip strength significantly decreases, then we're going to let the physician and the medical team know that in case it's part of some type of other secondary conditions or secondary symptoms. Again, we promote physical fitness, assess appropriate seating for mobility, and then parent and caregiver education, as well as getting out and talking to the teachers and community providers as well at that point.
So as our kids get a little bit older and start to transition into adolescence and into adulthood, we need to also think about their independence out in the community in terms of whether or not they're going to have a job or go to college. So kind of that independent mobility in the community sense becomes even more important. We want them to continue to participate in their school and social and recreational activities. They're going to need to continue doing a home exercise program to maintain their strength and their function. They still may be receiving school-based therapy or outpatient therapy. And we always want to keep in the back of our minds that things like the hydrocephalus and the tethered cord, as we talked about how spina bifida can be a changing condition over time, so we're going to continue to monitor for changes in their neurological status. Preventing deformity and secondary impairments, especially with regards to skin at this point, when the children become heavier and less mobile for some of our kids. Their skin and issues with skin breakdown often become more pronounced at this time. So really making sure they're able to do skin checks and have kind of a daily routine and schedule for that is going to be important. And then we're going to continue to look at their orthotics and their adaptive equipment, whether it be changing from a walker to crutches or vice versa, or going from walker to wheelchair. We'll talk a little bit more about that when we get to seating as well.
So again, with the adolescence transition to adult, it's basically the same kind of things with the visual motor, the fine motor, depending on, at this point, they're going from middle school to high school, and so we're going to be looking more at accommodations, and are they going to need writing accommodations and things like that in place. We start doing interest checklists because I think that's really important for adolescence and into adulthood, is finding an interest besides texting your friends and sitting in front of the computer and web searching and those kind of fun things, but we want to have other interests as well. Upper extremity strength, and look for changes in neurological functioning, and then again assistive adaptive devices and seating positioning needs. And I want to kind of get through the adult section now too, so that we can spend some time. We've got about 10 minutes, so we can spend some time on the seating part of it. But with adults, independent mobility, again, independence with self-care skills, which not only includes the bathing, dressing, self-catheterization, but medication administration, transfers, bracing, and their skin assessment. So we want to see that they're independent in all of these things. Monitor strength and changes in function. Focus on specific skill sets for independence, and then this is the group too that's really big in health, that we want to work on their health and wellness to prevent obesity, to get them into participating in regular exercise. Look at what do we need. A lot of times that intrinsic motivation isn't always there, so looking at different assistive technology ways of using timers and checklists and things like that. And then, again, all of this is part of with the aging, the risk of fractures, the obesity, the skin integrity. As I had said earlier, they're prone to peripheral nerve injuries like carpal tunnel or issues, and then earlier arthritis, pain. As they get older, the ambulation part where they may have been, using crutches at some point, then they may need to transition into more wheelchair assistive mobility devices. And then diminished nerve function can lead to decreased sensation and decline in circulation in their legs and their feet.